Thank you for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health seminar series, Turning Evidence into Action, Advancing Youth Mental Health Across Africa. Please take a moment to follow us on LinkedIn and Facebook, as well as Blue Sky and Instagram at #FSM Global Health. In addition, we welcome you to become an Institute member, which takes all of about 60 seconds. And if you are a member, you're going to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Okay. The Havey Institute for Global Health is thrilled to host one of our own, Amy Van Pelt, at today's seminar. Dr. Van Pelt is an assistant professor in the Department of Medical Social Sciences and the Center for Dissemination and Implementation Science. She serves as the Associate Director of Research within the Havey Institute for Global Health, Ryan Family Center for Global Primary Care, one of our only endowed center, actually. Her work focuses on increasing the uptake of evidence-based interventions in resource-limited settings, particularly low and middle-income countries in Latin America and Africa. She has collaborated with government, academic, and not-for-profit institutions and has a substantial record of NIH funding, publications, and awards, including the Havey Outstanding Global Health Educator Award. Congratulations. We welcome you to submit your questions, please, through the Q&A feature at the bottom right-hand corner of the screen, not the chat box, but the Q&A feature. So that would be, that's really kind of the best way. Lisa Hirschhorn will be leading the Q&A session if her connection from London is still working. Okay, and now, Dr. Van Pelt, I turn it over to you. You have, the whole session is yours. We look forward to your presentation and thank you very much for being with us and presenting today.
Great. Thank you. Good afternoon or good evening, depending on where you all are zooming in from. I am really excited to be here today to talk to you all about a growing portfolio of research where we're trying to turn evidence into action to advance youth mental health across Africa. Why focus on mental health today? More than 1 billion people are living with mental health disorders around the world. And when we talk about mental health disorders, these refer to clinically significant disturbances in an individual's cognition, emotional regulation, or behavior. There are many different types of mental health disorders, some of which you probably are more familiar with, including anxiety, depression, post-traumatic stress disorder, bipolar disorder, etc. What you may not be as familiar with is that suicide is one of the most pressing global health problems. We see cases of suicide all around the world, but this is especially true for low and middle income countries, or LMICs. Low and middle income countries account for 73% of the world's total deaths from suicide. And this burden is especially high for youth in these settings. Looking at this figure here, after road injuries and interpersonal violence, suicide is the third leading cause of death among youth in low and middle income countries. And you can see in the subsequent two bar charts that the high mortality rates persist regardless of sex. Males do experience a slightly higher number of deaths to suicide, but suicide is the second leading cause of death among female youth. As the director of the World Health Organization, or the WHO, stated, transforming mental health services is one of the most pressing public health challenges. And I would just add to that transforming mental health services for suicide prevention is one of the most pressing challenges. Why is that? We do know that many evidence-based practices for suicide prevention exist, but implementation of these practices is not optimal in low and middle income countries. There are a lot of gaps between what we know and what we do when it comes to the implementation of suicide prevention in these settings. So This bridge here was actually created by Dr. Sarah Becker and colleagues at Northwestern that highlights essentially 4 gaps between what we know from the evidence and what we do in practice. When we're thinking about the implementation of suicide prevention in low and middle income countries, a scientific gap may be that there's a lack of validated tools that are available. An expertise gap may be there's few trained mental health clinicians or professionals in these settings. A lack of mental health resources in general may contribute to a public health supply gap. And finally, there may be a public health demand gap due to a variety of factors such as stigma against mental health in these settings. One region that really experiences all of these gaps is the African region. The African region has the highest age standardized suicide rate at 11.2 deaths per 100,000. To illustrate this high burden of disease within this African region, Ethiopia, for example, reports 6.17 deaths per 100,000. But what I find particularly striking is that Botswana ranks as the 24th highest country with regard to the number of deaths due to suicide among all countries around the world. This suicide rate is not completely surprising once you dig a little bit further into the data, particularly considering that mental health implementation is not prioritized in countries in Africa. Here is a figure where in purple you can see the median percentage of total government health expenditures that are allocated to mental health. So on the left, if we look at low and middle income countries in general, it's substantially lower than high income countries. If we zoom in on the right and look at the African region, less than 1% of expenditures are allocated to mental health. The World Health Organization, or the WHO, has recognized this growing problem. They developed an implementation guide for suicide prevention called Live Life. It essentially includes the core pillars of situation analysis, multi-sectoral collaboration, awareness raising and advocacy, capacity building, financing, and surveillance and monitoring and evaluation. I've also recognized this as a growing problem. I mentioned at the start on the title slide that this is a growing portfolio of research. I'm an implementation scientist and an epidemiologist by training who has worked in many resource-limited settings in low and middle income countries for over a decade. But historically, I've worked in other disease areas like HIV, malaria, and other infectious diseases. But over the past couple of years, my partners expressed this great need to address mental health challenges among youth, which in part is due to youth growing older due to the success of other interventions. For example, we've been successful in implementing antiretroviral therapy among youth living with HIV. So now other conditions are emerging as these kids get older. With all of that, youth has become a new research priority for me and my teams. Specifically, we've found a need to adapt and implement suicide prevention for youth. And today I'll share a high-level overview of 2 projects that are adapting and implementing prevention for youth in Ethiopia and in Botswana. You can see the many folks who are collaborating on these 2 projects here. On the left is the team for the work in Ethiopia. We are working in collaboration with 4 institutions. And on the right is the team for the work in Botswana, where we're collaborating between 2 primary institutions. Across all of these folks, though, the teams really bring a lot of diverse expertise in suicide research, global health, pediatrics, implementation science, the local context, et cetera. Like all global health research, but particularly global implementation research, this is really a team sport. So I want to acknowledge these folks before I share some of the approaches that we're taking on our projects. What's the main goal of this portfolio of research? To hark back to the title of this talk, we're trying to turn evidence into action. Some of you may be familiar with the statistic that it takes approximately 17 years to translate research into practice. And we see this delay in the implementation of suicide prevention interventions in Ethiopia and in Botswana. Implementation science helps us close these gaps. Just in case there are folks who are not familiar, implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. Or in other words, what I like to say is that implementation science helps move the needle to make sure people get the things that work. Given the various levels of implementation science knowledge on the talk, I do want to provide a brief overview of some of the key concepts in implementation science while I highlight our two projects in Ethiopia and Botswana that will hopefully help concretize those concepts. So first, really central to understanding whether or not implementation research is appropriate, whether you're ready to do implementation research, is there has to be an evidence-based thing to be implemented. This could be a variety of different things like procedures, pills, programs, practices, products, principles, policies. We call these the 7 Ps. Essentially, it's our intervention or our innovation that has demonstrated clinical effectiveness in improving some health outcome. For the project in Ethiopia, we are implementing a multi-step thing that we're calling our suicide prevention package. If you look in the blue box, so the first step, we are administering a screening via the Ask Suicide Screening questionnaire that assesses suicide risk. Step 2 in the green, we are conducting a clinical assessment called the Brief Suicide Screening Assessment that really helps us better understand suicidal ideation and behavior. And then finally, in the peach here, we are administering a safety planning intervention. As part of our project, we actually proposed the possible use of 2 different safety planning interventions. On the left here is the safety planning intervention, or SPI, which is a 6-step intervention that people can use when a suicidal crisis is emerging. This template includes different elements like the identification of warning signs, internal coping strategies, people or settings that can provide distractions, people or agencies that they can ask for help, and then finally ways to make the environment safer. On the right is Safety Acute, or FISP, which is a cognitive behavioral family intervention that builds coping skills, enhances motivation for follow-up to mental health treatment, and improves linkage to outpatient services. In Botswana, we're also implementing a multi-step suicide prevention package, but this consists of different components. For screening in the purple, we're administering the Columbia Suicide Severity Rating Scale, which is a 6-item screening tool to assess suicide risk. In yellow, we're actually in the process of finalizing the determination of our clinical assessment tool because we've added this in as we've started this project because we think it'll be helpful for the success of implementation given who our deliverers are, which I'll share that with you all in a moment. But tentatively yesterday, actually, we landed on using the BSSA as well. And finally, for the intervention, we're also using the SPI, which was the first templated intervention that was on the left on the previous slide. In Ethiopia, we are implementing this package for youth aged 10 to 18 years in outpatient hospitals in 4 regions across the country. You can see here on this map, they're pretty spread out geographically across the country. These sites also have a lot of diversity in other factors, so rural versus urban, diversity in size, some smaller, some larger, as well as the population served, so different ethnicities in the different regions. In Botswana, we are implementing this package for youth aged 10 to 25 years in public schools in Gaborone. For those who aren't familiar with Botswana, Gaborone is the capital city. We're in the process of randomly selecting which schools within GABS will be the implementation sites, but it will include 6 public schools specifically within the southeast region of Gaborone. As you may have inferred, based on the differences in the implementation sites, context is going to be really central to our work here. A key point in implementation science is that context is not seen as a problem. In some of the traditional effectiveness or efficacy trials that you all may be more familiar with, I feel like we often try to design or control for differences between sites, but in implementation science, context is really considered and truly influences the design of our implementation. When we're considering the context for implementation, we need to start with the fit of our intervention. A thing that's designed for one context may not fit another context. And if I could see all the faces on the screen, I would ask, who remembers that game as a child where you had to put the blocks into different shapes? So if we tried to take a triangle block and put it into a circle hole, that's not going to fit very well. We would have to do something to make that block a bit rounder to fit into the hole. And we can apply that abstract concept to think about our interventions or our thing as well. If we try to implement an intervention that was designed for one context and implement it into a different context, it may not fit very well. This is particularly true for our interventions in our 2 projects. Safety planning is an evidence-based tool that was developed in the United States, but our teams are trying to implement it for kids in Ethiopia and in Botswana, which these are obviously very different contexts. Again, if I was teaching, I'd go around and ask the audience, what factors do you think may affect the fit of our intervention in these settings? But given we're in a webinar, I'll just preview some of the answers and share that there are many cultural factors, such as beliefs about suicide or stigma against mental health, political factors, such as the legality of suicide in these countries, as well as individual factors, so how youth express emotion. And combined, all of these considerations may affect the fit of our safety planning in Ethiopia and in Botswana. This is where adaptation comes in. Adaptation refers to changes to either an intervention and/or to a strategy or as a characteristic of an intervention. Adaptation really helps us make our thing fit the context better. The first key step in our projects and really global implementation research in general is a need to adapt the intervention to help it fit the context better. To do that in our projects, we are using the ADAPT-IT framework to guide the adaptation of safety planning specifically. For those who come from the HIV field, you may be familiar with ADAPT-IT, given that ADAPT-IT originally comes from the HIV literature, but it has been used across contexts and disease areas for a really long time. It includes 8 steps that elicit inputs for needed changes all the way through the integration and the production of our adapted thing or our adapted intervention. To operationalize this approach in our projects, we're using slightly different methods where we're focused on broader needs assessments for mental health services in Ethiopia, and then focus group discussions targeting questions related to the suicide prevention, specifically the suicide prevention package, in Botswana. Once we have input on what we want to adapt, we are leveraging participatory methods to really operationalize and prototype these adaptations. Human-centered design, or HCD, is one of the participatory approaches that we're using in both projects. Here are some of the photos from the HCD workshops in Ethiopia, where the stakeholders, the constituents, helped us adapt and design prototypes for our adapted safety planning intervention. It was a lot of fun. What are they working on in those pictures? What are we hearing as potential factors that could affect the fit of our thing and therefore require adaptations? The first, as you probably would expect, are language considerations. In Ethiopia, we expected to translate our package into Amharic, but we also have since learned the need to translate into Oromo as well to better fit the needs of the population in one of our sites. We also have to consider the literacy levels as a potential concern. So we're adding different visuals like emojis or faces or utilizing color to indicate different levels of risk and applying these to our various tools to help with comprehension. And finally, we also need to consider cultural factors like emotional expression. For example, in Ethiopia, we've learned that there are only 3 primary emotions that people express. So we need to modify some of the language that we have describing warning signs for suicidal ideation and behavior that the tools include to make them fit within the ways in which children express emotion in this context. Given the relevance to the group, I also want to just take a moment to expand on the language adaptation process. We are primarily following the World Health Organization guidelines for linguistic translation, which are really the gold standard approach, which involves 3 steps. First, the forward translation. If we take Botswana for an example, Setswana is the local language, so we'll take the tools from English and translate them into Setswana. Then we have back translation, where we're taking the translated Setswana version and translating it back into English by a different individual. Then we compare. And finally, we have cognitive interviewing, where we have various stakeholders review our translations and suggest any final modifications. In addition to the factors that affect the fit of our thing or intervention, there are various factors that may affect implementation of the package in these settings as well. And another key lesson in implementation science is that implementation strategies address specific determinants. Before I get into the technical jargon of strategies and determinants, I want to oversimplify this for a moment. So imagine that you're trying to implement a mobile application in a setting that does not have smartphones. As you would anticipate, implementation is going to fail. We are not going to be successful with this approach. Similarly, we are tailoring our strategies to the specific contextual factors in Ethiopia and Botswana. When we say contextual factors, we're referring to implementation determinants. Determinants are conditions that make it harder or easier for others to do the thing. They really influence the successful implementation of our evidence-based innovations. Determinants can be both positive or negative. When we talk about negative factors that affect implementation, these are referring to barriers. These are factors, again, that make it difficult or hard to do the thing. They can include a lack of resources that are available, insufficient time to implement the thing, staff turnover, resistance to change. I could go on and on. On the other hand, facilitators or enablers are positive factors that affect implementation, and these make it easier to do the thing. I do want to just call out, because I think the language can be confusing sometimes, that when we say facilitators, we're not necessarily referring to an individual who is delivering an intervention, but rather these are factors that already exist in the setting in which we're implementing our thing. So perhaps factors within the hospitals in Ethiopia, like resources that are currently available or standard operating procedures that are already in place, or perhaps they have a strong culture of communication between employees and between clinicians. Once we understand our implementation determinants, we then use that information to inform the tailoring of our implementation strategies. Implementation strategies are how we implement our thing. Formally, they are defined as actions taken to enhance adoption, implementation, and sustainability of evidence-based interventions. We're using 2 slightly different approaches to tailor our implementation strategies in these projects. On the left in Ethiopia, we are first conducting needs assessments and then selecting implementation strategies. On the right in Botswana, we're completing semi-structured interviews and conducting a process called implementation mapping. Implementation science, the field loves our theories, models, and frameworks. So want to just highlight two that we're applying in our projects. We're using the Consolidated Framework for Implementation Research, or CFIR, to guide our contextual inquiry in both projects. CFIR is essentially a multi-level framework that includes 5 domains across multiple ecological levels. So the outer setting describes external factors like government policies. The inner setting refers to factors within the site that we're implementing our thing, like relative priorities, available resources, mission alignment, etc. Individuals describes both the recipient and the deliverer, so potentially patients and clinicians, and their characteristics such as self-efficacy, implementation process, and then finally the innovation or the thing, specifically characteristics related to the innovation. So aspects like its complexity, its design, its cost, etc. CFIR is very popular, so you are likely to encounter this in your work or review of literature if you're exploring any implementation work. And then one other taxonomy to share with you is for implementation strategies called the Expert Recommendations for Implementing Change, or ERIC compilation. I won't go into detail here, but I do just want to mention it because folks may have heard of ERIC and are wondering, who is ERIC? But essentially, it's a list of 73 discrete implementation strategies. They're disease agnostic, fairly comprehensive, as you can see here. So ERIC often serves as a starting point for teams that are trying to determine which strategies to use in their studies. We did select some implementation strategies a priori or before the start of the study based on factors that we anticipated or we knew would pose a problem to implementation. For example, in Ethiopia, we're using the strategy of facilitation to address the lack of mental health resources that are available in this setting. Facilitation is an implementation strategy that essentially is a process where external facilitators or external folks help problem solve challenges that arise during active implementation of the innovation. In Botswana, the main implementation strategy is task shifting to address the barrier of few trained mental health professionals. And task shifting, I anticipate, is probably quite familiar with many of the folks on the call, given the global health audience here. But for this work, we are having guidance and counseling teachers administer our package instead of psychologists. You remember earlier I said that the selection of our thing needs to consider the deliverers. This is what I meant. Given the role of the guidance and counseling teachers, the use of the tools or the components that we have within our package for Botswana are more feasible among these non-specialists. Across both projects, we are also deploying the strategy of training via educational sessions to address the lack of mental health professionals, as well as the need to really build capacity on all components of implementation, as well as our study workflow. A key element in this training, as you would anticipate, is how to actually administer or deliver the suicide prevention package. Once we finalize our implementation strategies, the next step we want to take is to measure how much and how well we did our thing, which refers to implementation outcomes. More formally, implementation outcomes are the effects of deliberate and purposive actions, aka implementation strategies, to implement new treatments, practices, and services. The last framework here, I promise, a popular implementation outcomes framework is Proctor's outcomes. Enola Proctor is really one of the queens of implementation science. If you look on the left box here, you can see that some of the things we measure in implementation science are acceptability, penetration, which refers to the number of individuals who receive our innovation divided by the total number of eligible individuals. We also evaluate feasibility, fidelity, which is how well our intervention was implemented as it was designed to be implemented, et cetera, costs, appropriateness. Our approach to the measurement of the implementation outcomes in our two projects will occur via a hybrid effectiveness implementation trial. These trials measure both clinical effectiveness outcomes and implementation outcomes at the same time. If you look at this figure, you can see broadly there are three types of hybrid designs. On the left, a type 1 prioritizes the evaluation of clinical effectiveness of our thing or clinical effectiveness of our intervention, while we're collecting some information about implementation along the way. On the other end of the spectrum, on the right, the type 3 prioritizes the evaluation of the implementation process while we're collecting some information about effectiveness along the way. And then right in the middle is the type 2, which is a bit of a beast because it's a dual evaluation of both clinical effectiveness outcomes and implementation outcomes. For our work in Ethiopia, we are conducting a type 1 trial given the decision to combine elements from two different safety planning interventions and the lack of robust evidence on the effectiveness of that combined intervention in that form. For the work in Botswana, we're conducting a type 3 trial given that adaptations will primarily target aspects such as language, format, visuals, cultural considerations. Through these different trials, we have a range of outcomes that we want to measure. In Ethiopia, our primary outcomes are suicidal ideation and behavior, which refers to thoughts and actions. Again, I want to highlight these are our clinical effectiveness measures, but we're also interested in measuring implementation outcomes such as REACH, which we are defining for our study as the proportion of youth who receive the appropriate pathway, as well as interested in some secondary measures of REACH and looking at the specific components of the package. So the number of youth screened, the number of youth assessed, and the number of youth who receive the safety plan. With regard to fidelity, we will evaluate the quality of the safety plans created, acceptability of the safety plan, feasibility of the package, as well as self-efficacy, which refers to an individual's belief in their own capabilities to implement the thing. And here I want to highlight that self-efficacy is more of a mechanism through which the strategies promote change in the outcomes. On the other end of the spectrum, for the work in Botswana, our primary outcomes are implementation outcomes of acceptability, appropriateness, feasibility, and fidelity. I did define those other outcomes on the slide except for appropriateness, but appropriateness is what it sounds like. It refers to the degree or the perceived fit, relevance, and compatibility of our intervention. We're also interested, though, in making sure that our adapted package is effective. So we're measuring suicidal ideation and behavior as well as suicide-related coping, which is an individual's knowledge and confidence in using internal coping strategies and external resources to manage suicidal ideation. For this study, that is one of our mechanisms. I want to take a moment to pause. I mentioned mechanisms, but didn't cue that up with the implementation science language. So just want to explain this concept a little bit further. In a formal definition, implementation mechanisms are processes or events through which implementation strategies operate to affect one or more implementation outcomes. Or in other words, they're how actions to do the thing actually works. We have many fancy ways to visualize implementation mechanisms in implementation science. For example, we can use causal pathway diagrams, but I want to simplify it here. So this is for our project in Botswana. This actually comes from a grant application. So the way we explained this to folks outside of our research team. So given the hybrid trial, we are measuring mechanisms for both the intervention as well as the strategy. The top row here refers to the intervention, which is the safety planning intervention that is aiming to reduce suicidal ideation and behavior. The way in which that works is by increasing suicide-related coping skills. On the bottom, given we're interested in the implementation process, we also wanted to examine a mechanism for the implementation strategy. So if we look at the teacher training or the educational session as an example of our implementation strategy that will improve the implementation outcome of fidelity, that will work through increased self-efficacy, increased knowledge on our thing. So that was a lot of information that I just shared with you. And for some folks, implementation science may be completely new. So you're not only trying to digest two different projects, but also the concepts in the field. So I do want to just take a moment to bring this all together in a more visual format. We have a helpful tool called the Implementation Research Logic Model, or IRLM, that helps visualize the different components in implementation research. And want to shout out that the IRLM was developed by colleagues here at Northwestern, which is really exciting how we have such a great implementation science and global implementation science community at our institution. The IRLM is a tool that helps us see how we do our thing. If we start at the bottom here, we need to identify our evidence-based practice or our innovation or our thing. From there, we specify what the clinical health outcomes are. So these are not related to implementation science, but I do think it's helpful to identify them in advance because we know then what we're not measuring for our primary implementation research. Then we think about our implementation determinants. These are the factors that influence implementation. This IRLM is organized by the Consolidated Framework for Implementation Research, or CFIR, that I shared with you briefly when orienting our work. Then once we know our determinants, we try to target strategies to address those factors. And these are the stuff that we're doing to do our thing. Finally, once we have our implementation outcomes, our implementation strategies, we deploy those. We want to know how much or how well we did the thing. And we want to make sure these outcomes are relevant to the strategies that we align in the box previously, as well as making sure the strategies address the barriers and facilitators, which you can see denoted by all the different arrows in this figure. Here you can see how this all comes to life with the work in Botswana. So if we start on the bottom, the innovation is our suicide prevention package, which happens to consist of 3 components of screening, assessment, and safety planning. Theoretically, it will improve, or I guess reduce suicidal ideation and behavior as our clinical health outcome. Some of the determinants include stigma against mental health and suicide, a lack of mental health clinicians in schools, and a lack of knowledge on administering the suicide prevention package. Based on that information, some of the strategies that we've proposed and we are deploying include task shifting delivery to guidance and counseling teachers to address that intersetting barrier of the lack of mental health clinicians, deliver training to address the individual barrier of a lack of knowledge on administering the package, and finally, ongoing support given stigma against mental health and suicide in this setting. So there may be various problems that arise during the trial that we will be providing ongoing support via monthly meetings to help troubleshoot. As we reach different milestones in these projects, it's been really helpful to reflect on generalizable knowledge that we've been able to glean from both studies. First, we know that co-design of both adaptation and implementation has been really key. We also know that the thing needs to be appropriate for our target setting, which is highlighted by the different components that we have for our suicide prevention packages in each of the projects. Adaptation has really been an iterative process. We have multiple steps where we're engaging constituents in the elicitation of ideas for modifications, as well as prototyping our adapted things. And finally, multi-level implementation strategies are needed, as you can imagine, but we're also learning through our contextual inquiry. There are factors that cross multiple ecological levels that may affect implementation of our package. So having actions that target these different levels is really key for our success. And these learnings aren't unique to these two projects. We're now taking what we've been learning in Ethiopia and in Botswana to a new project in Malawi, where we're developing approaches to adapt and implement suicide prevention for youth aged 10 to 25 years in teen clubs. And given this implementation site, primarily targeting youth affected by HIV in rural Malawi. As we continue to grow this portfolio of research among our teams, we are learning that reducing suicide among youth in low and middle income countries and really across the globe requires cross-contextual reciprocal learning. This is a global health problem that requires global health collaboration. I could stop here, open it up for discussion, but I do want to just address the folks on the call who may be thinking, how is any of this information I just presented to you relevant if you don't work in mental health? So first, thanks for sticking on the webinar, but I do want to end by bringing us back to the beginning of the conversation where we talked about how implementation science can really help us advance global health, which are transferable approaches that you can apply to any of your work outside of mental health, if you work in HIV, cancer, any different settings. Why is that? I showed you that we have a 17-year research to practice gap. Implementation science can help us shrink that gap to help get evidence-based interventions into practice faster. We can really only achieve global health impact if people are actually using our interventions. And this is true for mental health and suicide prevention, but of all evidence-based practices as well. What I often like to say is that an intervention that's sitting on the shelf serves very little purpose to the community. And we can look at this quantitatively. We can consider innovations or things that are 100% effective in a controlled environment. And I'll branch out for a moment to engage the diverse folks on the call, but also a bit more into my roots here. We can think about antiretroviral therapy for the treatment of HIV or PrEP for the prevention of HIV. Under perfect circumstances, this would mean that we would achieve 100% population impact. Replace ART, replace PrEP with a mental health intervention that is 100% effective in a controlled environment. Again, we would have 100% population impact, theoretically. But we know we don't live in a perfect world. We don't have perfect circumstances. So perhaps only 50% of our agencies choose to actually offer ART or PrEP or deliver our mental health intervention. Then only 50% of the providers follow that protocol. Then only 50% of those providers actually offer it to clients. Only 50% of those clients use it. And with all of this, only 50% of agencies continue to offer it. This, as you can imagine, would lead to a significantly lower population impact, whether that's looking at HIV or looking at mental health. And implementation science is really helpful for understanding what is happening in these different levels. And I want to close by thinking about, as global health researchers, we think about this on an even larger scale. For those who aren't familiar, the Sustainable Development Goals are key metrics essentially for improving the health for all. And in order for us to meet these targets, we need to do better than achieving a 3% population impact. And this is true in all settings, because in order to meet these global goals, we need contributions from all countries, which means facilitating implementation research in low and middle income countries as well. I see we're about at time, so I want to make sure we have plenty of time to have a discussion. I have a couple of slides that are related to resources at Northwestern for implementation science if you're interested in learning more, but I can just flash those on the screen for a moment while we start collating the questions in the Q&A.
So thanks so much, Amy, for really great both, what is implementation science and how do we actually do it for that. Apologies, I don't have my video on. My internet's become a bit unstable, but we have an initial question from a teen. Suicide was declared a national emergency in Northern Canada among Aboriginal First Nations youth. What can high-income countries offer to LMICs in youth suicide approaches? Thanks.
That's a good question. So I do give the caveat that I'm not a mental health clinician. I'm very new to suicide research. So I'll think of this more of like a broader perspective on it. So we see mental health stigma in the settings that we're working in Ethiopia and in Botswana, but just personally in high income countries, I've also experienced stigma. So I think something that could be helpful if folks in high income countries have been effective in combating stigma against suicide, stigma against mental health in their countries, and sharing those learnings to our colleagues and our partners in low and middle income countries. That would be very valuable because I know stigma, regardless of what your intervention is a really hard strategy to address. Or sorry, a really hard barrier to come up with a strategy to address.
Thanks. Anybody else has questions? Please do put it into the Q&A. In the meantime, what advice would you give somebody, especially in this sort of era, who wants to actually do work in global health and sort of how to think about going about doing it?
Yeah, great question. So I think first you need to build a relationship with your partners in whichever countries you're hoping to pursue global health, because you really should be co-creating what your implementation research or what your global health research is. And I think I alluded to that when I described that I didn't work in mental health. I worked in infectious diseases, and my partners in different settings started articulating the priority to shift to the prevention of suicide. So I would say that relationship building piece is really critical. And then through conversations, you can start to identify some priorities, and then we can get into the details of how do you actually pursue that work. But for folks who are at Northwestern, Havey is a great resource. There are a lot of different centers working in a variety of different disease areas. So perhaps a starting point would be reaching out to a center that is clinically aligned with what you're interested in and seeing how you can build relationships with some of the partners that already exist.
Great. And we have a question from Gazachu Tirane, who is the new director of the Implementation Science Cluster at the Leap Center at University Global Health Equity. His question was, what are your thoughts on adapting strategies to scale this intervention within primary healthcare settings to reach more youth in Ethiopia?
Great question. So it's going to depend on what the context in the primary care settings look like compared to the hospitals. I don't think I shared that in the hospitals we're working in the like the emergency department, essentially. That's the specific ward. So we have general clinicians there. We don't have like mental health professionals that we're working with, except for some do have psychiatrists who are on call. So I do want to caveat that. So I think some of the generalizable learnings will be that some of the strategies that are targeted for non-specialists in the hospital can probably be applied to the primary care setting. Workflow will have to look a little bit different because we do have the psychiatrist that we can refer to. So if there's a child that screens high risk, rather than them going to assessment and intervention, if they're in a crisis, they will automatically get referred to psychiatric care, which involves certain implementation strategies. But if that doesn't exist in the primary care setting, that implementation strategy may have to look a little bit different, and we won't be able to exactly scale up. So we'll have to tailor and adapt what that referral or what that workflow would look like. So yeah, the two things that come to mind right away are the strategies that are going to be relevant are related to deliverers, but some of the infrastructure, some of the workflow strategies might need to be tailored given the infrastructure isn't the same in a primary care clinic versus a hospital outpatient setting or hospital ED, sorry.
Great. Thanks for that. If there aren't any other questions, I do have one more, which is, NIH is very big on what they call reciprocal innovation. So that's where you have innovation that might come from Ethiopia to the US and back again, or US, Ethiopia back to the US. I'm wondering if you could talk about what some of the potential opportunities are for that type of reciprocal innovation in either or both of the projects that you're working in.
Yeah, good question. I could say first, The Ethiopia project is about a year ahead of the Botswana project. We're in year 2 in Ethiopia, year 1 in Botswana. So we're even having that reciprocal learning within the two countries as we're figuring out how things work or what factors may be barriers in Ethiopia. If there's anything generalizable, like language, we're bringing those insights into the project in Botswana like a priority to try to figure out how can we do this more effectively at the start. So that's been really interesting, but that was not your question. Your question was how can we be reciprocal through our work in Ethiopia and our work in Botswana back to maybe the US for folks who may do suicide prevention here. I think we are way ahead, honestly, in task shifting in countries in the African region and particularly in Ethiopia and in Botswana. So any of the success that we have in deploying a task shifted strategy for the mental health intervention or just in general for any intervention, I think we can bring those learnings back to the work that we're doing in the US because we're many years ahead, I think, in our global settings and being successful with deploying those approaches.
I think
Great.
this is a question that's going to come up with every single grant we have. I mean, we have to really just upfront address that issue.
Yeah.
Yeah.
Rob, any last questions from you or from Kate? Otherwise, I'm going to bring us to a close and give everybody a few minutes back.
Yeah, okay, great. No, that's fine. I don't have any other questions. No.
Okay. So first, obviously, really want to thank Amy. She's, really a great partner in our center, the Ryan Family Center for Global Primary Care, as well as leading a lot of really great work in implementation science. For those of you who've taken the reading course, she's one of the leader and also in charge of developing. Correct me if I'm wrong, Amy. You're the course in implementation science. And we invite you to join us at our next Institute of Global Health seminar taking place virtually via Zoom on Wednesday, March 4th. Be presented by Imran Mohsen Bello, who is professor of obstetrics and gynecology at the University of Ibadan, talking on cervical cancer elimination agenda in Nigeria towards 2030, prospects and challenges. And you can register via our newsletter, Plant Purple, or social media pages. Or for those of you who are on our newsletter, you'll get it there as well. Again, thank you for joining us today. Recording the webinar will be available online and will be shared via our newsletter. And this concludes today's webinar.
Thank you very much, Amy.
Thank you.